Hi, everybody. It's Dr. Eric Balcavage, and I'm joined by my co-host, Dr. Eric Riggleman. Hi, Dr. Riggleman.
Hello.
How are you today?
Good.
And today this is our 8th podcast, and today we're talking about hypothyroidism and its connection to the sex and adrenal hormones. And today's going to be kind of an introduction to all those. We just don't have enough time in today's podcast to talk in depth about each one of the hormones and the interconnection between it. So we're going to give a highlight on each one of them. And then in the future, we've got some plans to break down in a little bit more in depth the connection between thyroid hormone and estrogen at a deeper level, and progesterone and cortisol. We'll get deeper into each one of those on individual podcasts. We actually have an analytical, which that company is an amazing company. They run the Dutch test, which is, in my opinion, the premier hormone panel that can be done to take a look at your cortisol levels and the metabolites and your all the sex hormones as well and all their metabolites. So we're talking about hormones and the connection with hypothyroidism today. So I think what we'll do, if it's all right with you, Dr. Erica, let's just start at the top, and probably the one that's probably most important to females, and that is the connection between thyroid hormone and hypothyroidism and estrogen metabolism. You want to touch on that just a little bit to get started?
Well, absolutely. And it's one of those things with the chicken or the egg. So a lot of times people will become hypothyroid and then start to have sex hormone estrogen issues, or they may be already having estrogen issues, which then lead to more thyroid hormone issues down the road, especially in pregnancy or even in adolescent years. Signs start to show up. They may not have hypothyroid symptoms, but they may be starting to show, abnormal cycles, the heavy bleeding, lots of cramping, PMS symptoms. And the solution for most people is, let's just put you on birth control and see how that goes. And oftentimes that just leads to a more whole host of other issues downstream, because lack of thyroid hormone is definitely going to impact the way that estrogen actually breaks down in the body. So having low thyroid hormone is actually going to favor more of that 16-OH breakdown of estrogen, which is less protective against a lot of different estrogen-related cancers downstream.
Right. So you got, for those of you who don't know, when estrogen, there's three estrogens, E1, E2, E3. They go through phase 1 metabolism, and they break down to these hydroxylated estrogens. There's a 2-hydroxylated estrogen, which is what we would like to see the most of. There's 4-hydroxylated estrogens, and there's 16-hydroxylated estrogens. 2-hydroxylated estrogens are the most beneficial because they're the easiest to metabolize out of the system. The 16 and the 4-hydroxylated estrogens can be more damaging and more toxic. And so we really want to make sure that when we're looking at estrogens and estrogen levels, we can't just look at the primary metabolites. Primary hormones, we have to actually look at the metabolites, because if you don't, a person could have low estrogen levels as a primary estrogens, but they may have high levels of these secondary metabolites that can drive estrogen dominance. So they can have estrogen dominance problems, yet their primary estrogens will look low. And unfortunately, doctors sometimes look at only the primary hormone. They look low, and so they put them on hormones or birth control, and that really creates some significant health problems for people. Mm-hmm. So yeah, and hypothyroidism, when somebody is hypothyroid, the shift is away from the 2-hydroxyestrogen and more towards the 4 and the 16. So that's exactly right. What other effects are important about estrogen that is really important that you think our listeners should know about?
Well, thyroid bindingglobulin is a big one, where it's where they bind the free hormone to be able to take it to the actual cell. When you have increased estrogens, you're going to have increased thyroid binding globulin, which then is going to reduce the amount of free thyroid hormone you actually have in circulation, which then can give you hypothyroid symptoms because you're not getting the thyroid hormone inside the cell, which often your TSH is going to be normal in those people. And so that often doesn't get diagnosed unless you're looking at the estrogens and the actual free, bound hormone in the circulation.
Right. So it can be a vicious cycle, because if you're hypothyroid, you're going to have more toxic secondary estrogens that then can create estrogen dominance. And when we have estrogen dominance, then we can have increased thyroid binding globulin. So you have more total T4, but less free hormone that's available for the tissues to get into the cells. And as we've talked about many times, thyroid hormone physiology is what's most important about it is not how much is in the blood, but how much is actually into the peripheral cells to actually stimulate metabolism. And that estrogen dominance, extra estrogen, also creates another issue, because estrogen will then inhibit thyroid hormone production, right? Mm-hmm. So estrogen inhibits iodine uptake at the thyroid gland. And so now you get less thyroid hormone produced, you have less active thyroid hormone, and now you can't metabolize thyroid hormone or estrogen appropriately, and it becomes this vicious cycle. Mm-hmm. And if you're not doing the right testing, as I was saying, you may look at the primary estrogens, and they could potentially look low because they're shifted in the wrong direction, and you get put on thyroid hormone. Or you have abnormal cycles, and somebody says, well, we're going to regulate your bleeding cycle with estrogen, and that can create a problem, right?
Because the birth control itself is the estrogen, which then is going to perpetuate that cycle even more and just creates more abnormal. And this is often what I see in my offices, that, at their teenage years, they showed those signs, they got put on birth control, and then in their late 20s, where they come off birth control and want to get pregnant, then they have infertility issues. And so they have thyroid issues, they have hormonal issues, but nobody really wanted to fix the underlying problem when it presented back in the teenage years. And, they get frustrated because they want to get pregnant and they want it to happen now. And then they go on more hormone replacement to try to, ovulation stuff and trying to get pregnant. And it just becomes this vicious cycle that keeps going and going. It can be very frustrating to many young couples who should be able to get pregnant, but nobody really did the proper testing to, fix the underlying issue.
Right. So a key thing is that if you have abnormal cycles, and before you go to hormone replacement or birth control to try and force a normal bleeding cycle, definitely thyroid physiology has to be looked at. Mm-hmm. And more than TSH and T4 has to be looked at, as we talked about before. So I think we got estrogen down pretty good, that kind of short review. Let's talk about progesterone, because that's another important hormone that needs to be looked at, addressed, considered. And overall, hypothyroidism has an impact on progesterone physiology, right?
Absolutely.
And so when we look at what happens with thyroid hormone and progesterone, thyroid hormone, when we have hypothyroidism, we have a tendency to have decreased progesterone receptor sensitivity. Mm-hmm. And so if the receptors are less sensitive, then we have progesterone that can't really do what it's supposed to do. So we could have low progesterone symptoms. A female could have low progesterone symptoms, and that could be some problems associated with getting pregnant, or headaches and infertility or miscarriages as an effect of just low progesterone activity. Mm-hmm. The levels could look normal, but it's the sensitivity at the receptor level that's important.
Yeah, and also the ratio of progesterone and estrogen together. You have to look at it as a ratio too, because again, you lower that progesterone, and then you may still have your period, but you may not be actually ovulating to actually be able to get pregnant.
Right. And so we'll talk about hypothyroidism definitely impacts FSH and LSH and the ability to ovulate. But one of the key issues, along with what we've talked about with hypothyroidism, is if you have symptoms of low progesterone, and that may be that heavy flow or inability to lose weight or headaches. You have to consider that progesterone levels still might look normal, but it's that receptor site physiology that may be a problem. And even thyroid hormone levels, again, may look normal, but most of those progesterone receptors are within the cell. And it goes back to what we talked about over and over again about cellular hypothyroidism. If thyroid hormone is not sufficient within the cell, it's within the cell that is where you find these progesterone receptors. Mm-hmm. So the levels could look good in blood. It could even look good in urine, but it's the thyroid, it's the inability to get thyroid hormone into the cell mm-hmm. to stimulate those receptors, which is the big thing. So just because somebody's TSH and T4 is normal does not mean they have sufficient thyroid hormone within the cell. They could have this cellular hypothyroidism, and when they do, they can't, the progesterone receptors won't work appropriately. They'll have the low progesterone symptoms, but they may have normal or elevated levels of progesterone.
Mm-hmm. Absolutely.
The other thing about progesterone is how progesterone, as its levels increase, it has an impact on the thyroid gland. And this can be an important factor for people who have Hashimoto's, because as you increase the levels of progesterone, it can influence or increase the production of TPO. And as if you have Hashimoto's or somebody has Hashimoto's, one of the common antibodies that is associated with Hashimoto's thyroiditis is TPO, thyroid peroxidase. So as progesterone levels rise, it influences or increases TPO activity. And as you increase TPO activity, that increases T4 and T3 production. And in a perfect scenario with no hypothyroid or with no autoimmunity, that's perfect. Mm-hmm. I need more thyroid hormone to increase my receptor sensitivity, so it's a perfect system. Unfortunately, for those with Hashimoto's, that increased circulating progesterone levels may actually increase their autoimmunity. So we have to be careful, and we don't want to, just because somebody has low progesterone symptoms doesn't mean we want to put them on progesterone. Especially we have to be cautious of them if they have autoimmunity. And too often people get put on progesterone. Oh, you just have low progesterone symptoms, We're going to put you on progesterone, not even considering the fact that if they have autoimmunity, they actually may make their whole condition worse.
Absolutely.
And I don't know if you want to point out that most of these, if you want to talk about progesterone, usually it's not that they can't make it, correct?
Yes. Yeah.
It's usually influenced by either adrenal issues, high cortisol, something like that, or the hypothyroidism that's causing the symptomatology of either low production or lack of sensitivity.
Yeah, the progesterone steal, where it's stealing it to, the adrenals are stealing it to do other mechanisms is a big thing. And going back to the autoimmune part of it, as it relates to hormones, if you have Hashimoto's, you already have an autoimmune disease, the likelihood that you have autoimmunity against your sex organs is pretty high too. So you could have autoimmunity against your ovaries or your testes. I mean, you could have that. So you could be having that in both levels, where autoimmunity against your thyroid, and then you have autoimmunity against your sex hormones, which then they play off each other and they just keep going. So, that's a big thing that I see, is where people already have antibodies against their ovaries, but they're also Hashimoto's. So it's very common, like we've talked about on other podcasts, to have more than one autoimmune disease.
Yeah, and we don't leave guys out of it, because guys get Hashimoto's and have hypothyroidism too, but definitely there's a big tie-in between when there's hypothyroidism, there is decreased testosterone production quite often, and there is often a reduction in libido, men and women, and men typically have other autoimmune attack definitely on their testes. Mm-hmm. From a LH and FSH level, we talked about hypothyroidism there. Overall, the suppression, hypothyroidism just really creates a decreased production of LH and FSH, right? And so the overall influence, if we talk about that, what's going to be that overall influence of a reduction of LH and FSH for the female specifically.
Well, that's going to lead to a reduced amount of progesterone receptor site sensitivity, isn't it?
Well, you're definitely going to have decreased ovulation, right?
Yes.
So if you're going to have decreased ovulation, it's going to lead to infertility, abnormal cycles. So if we've got a female patient who's got abnormal cycles, they're all over the place with their ovulation, definitely we need to be considering what's happening with their thyroid physiology. So we definitely have to take a look at that. I know I've had a number of patients who were unable to get pregnant, and they tried a bunch of different things to try and get pregnant, force their hormone replacement therapy. Didn't really work. Didn't work at all, actually. And it wasn't until we did two things. One, identified that they actually had a hypothyroid condition, and then two, identified what the cause of the cellular resistance was, which was a chronic infection. So addressing the chronic infection allowed for normal cellular thyroid levels, which allowed for normalization of ovulation and normalization of progesterone sensitivity, and therefore the ability to get pregnant, maintain a pregnancy. Mm-hmm. So instead of losing that pregnancy in the second trimester, they were able to maintain it.
Absolutely. So and then pregnancy itself can create, the shifts in hormones can then create a thyroid problem. A lot of women don't develop a thyroid issue until they get pregnant. And then they realize after that, all that change in hormones actually created a dysfunction in their body, which then they led to thyroid symptoms. Right.
Exactly. So from a position of getting pregnant, if somebody's female and they're struggling with infertility, first of all, if you have an abnormal cycle, you need to evaluate both your thyroid hormones, make sure you get a full thyroid panel, and make sure you get thyroid antibodies tested. And you definitely need to consider not just the blood hormone levels and the primary hormones, but they have to do a more extensive panel looking at the primary hormones and the metabolites along with their thyroid physiology, because those two things are so intertwined. And actually, one of the best tests that I know you and I both use and are very fond of is a Precision Analytical's Dutch test, which gives you all the primary hormones and the metabolites. And so you can see what's happening from the start all the way through to the detoxification process. Mm-hmm. So I think that's
very valuable test. Definitely is. I think it comes down to you have to realize that thyroid hormone at a cellular level, once it gets in, it's meant to speed up cellular metabolism. It's supposed to increase all activity inside the body. There's thyroid receptors on every cell in your body. And when you're not getting that thyroid hormone inside the cell, the body's slowing down. It's trying to slow you down. So, of course, sex is low on that totem pole of, what your body needs to do if it's struggling at a thyroid level. So, of course, your libido is going to go down. You're going to have abnormal cycles. Your body's trying to tell you that something's not right and slow you down, trying to fix the problem. And by just putting a Band-Aid and, giving you birth control or giving you excess hormones, you're not really fixing the underlying, problem. The body's really trying to tell you something and often gets ignored.
Right. And thyroid hormone is important from every aspect of female hormone physiology, male hormone physiology from that standpoint. I mean, it's one of the reasons why when a woman's ovulating, her temperature goes up, right? Because that's all the result of thyroid hormone increasing metabolism. So there's definitely a tie in there. I think one hormone we didn't talk about, and definitely my hypothyroid patients, sometimes we see this on blood work, is prolactin. Okay. And so when people have elevations when they're hypothyroid, there's a tendency to have elevated levels of prolactin. And as long as you're producing higher levels of prolactin, that too is going to affect fertility and ability to get pregnant, because as you increase that prolactin level, you're going to decrease ovulation, decrease LH, and it's going to be near impossible to have a normal cycle, near impossible to have the ability to get pregnant or at least maintain a pregnancy. So seeing elevations of prolactin levels is not unheard of when somebody has hypothyroidism. So we said that hypothyroidism can affect estrogen, especially the metabolism of estrogen. It can affect progesterone by reducing the sensitivity of estrogen, of progesterone at the receptor site. We talked about hypothyroidism can decrease LH and FSH. We talked about thyroid hormone can increase prolactin levels. And so overall, any disruption of thyroid hormone physiology is going to create a disruption in the normal female hormone cycle and her ability to get pregnant and or maintain a pregnancy, right?
Absolutely.
So let's talk about cortisol, right?
Okay.
So cortisol, critically important hormone that's released in the body, but thyroid hormone plays, those two things kind of tie together they're woven together pretty tightly. So when we see low thyroid hormone function, one of the things that can happen with cortisol is a stress hormone. We need to release it. We need to make it. It helps us have energy. It helps us do a lot of different things with regulation of blood sugar. So it's really important. But when we have excessive cortisol levels, that can lead to belly fat, and inflammation, and a number of challenges. But one of the roles of thyroid hormone is that thyroid hormone helps metabolize cortisol out of the system. So if you have low cellular levels of thyroid hormone or cellular hypothyroidism, then you can't metabolize cortisol, and you wind up with excessive levels of cortisol in the system, which drives stress, irritation, anxiety, weight gain, inflammation. So really important role there.
Absolutely.
Any other important things you'd like to talk about with cortisol and the relationship between hypothyroidism and cortisol production?
Well, cortisol is going to make you make more of that reverse T3 that we've talked about before, which is then going to block receptors, which then is just going to make you have more hypothyroid symptoms because you're not getting thyroid hormone inside the cell. And so with cortisol, there's probably an underlying reason. Stress in the body goes back to that stress we've talked about on just about every podcast. What is the stressor? Why is the body making that excess cortisol? And looking at that underlying reason is big.
So stress increases cortisol. High levels of cortisol increase reverse T3 and create cellular resistance, decrease transport, which causes especially the liver to not be able to metabolize cortisol, which allows for higher circulating cortisol, which kind of reinforces and creates this vicious loop. So what do you do in that situation? Do you give somebody more cortisol? Do you try and suppress cortisol? In that situation, I think you already hinted to this, but what's the thing to do in that situation?
You want to find out what's causing it to be high. Is it a chronic infection? Is it that the person's just extremely, emotionally or physically stressing their body that they need to reduce that? Looking at an adrenal panel to see, how can we support the adrenals and try to balance the production of that cortisol, and then looking at, thyroid function.
Yeah. So major issue there is if they have indications of hypothyroid symptoms, we have to figure out how we can support better thyroid conversion and better thyroid transport into the cells, because without thyroid hormone especially in the liver to help metabolize cortisol, they're going to have high levels of circulating cortisol, and that's going to be a vicious cycle. And you can artificially try and tweak that or try and manipulate it, but until we get sufficient thyroid hormone to metabolize it, they're going to struggle. So we have to reduce the stressors, the drive for the body to try and make more cortisol, while we try and as we do that, then we can support better thyroid transport and conversion, have more active thyroid hormone within the cell, and we can get more cortisol metabolism and get it out of the system, right?
Absolutely.
So people with thyroid hormone problems, the best way to look at that is by looking at blood work. And we've talked about that. A full thyroid panel is recommended. And our full thyroid panel is different from the full thyroid panel that their medical doctor and their endocrinologist are going to do. So why don't you tell the listeners what tests would be part of a normal comprehensive thyroid panel?
Well, of course, you're going to want to run TSH. I mean, that still is important. You want to be looking at the T3, T4, the free T3, free T4. You want to be looking at reverse T3, which is extremely important. And then you also want to be looking at the antibodies, because you want to be ruling out autoimmunity, and that's extremely important for, just determining whether it's an autoimmune condition or whether it's a true thyroid issue.
Right. And then if they want to look at their hormones, we probably need to talk a little bit about the Dutch test, right? Because we both agree that that's the best test that can be done. It's through Precision Analyticals. You can just Google www.dutchtest.com and you can find out everything you want to know about hormone testing. They've got great videos on there, educational videos for both doctors and lay people to understand their test, how hormones function, how they metabolize out of the system, what the test does, what it means, and how to test. But both you and I use that test on a regular basis.
Absolutely.
So a couple things we need to talk about the test is, if you're planning on doing the test, if you have a normal cycle, kind of that normal 28-day cycle, when you ovulate, then you pretty much can follow the directions in the test. And really what you're trying to do is do the test about 5 to 7 days after that ovulation, right?
Yeah.
So the problem occurs when you don't know what your cycle is, or you have an abnormal cycle. In that situation, I'm not sure if you do this as well, but I recommend that women get an ovulation kit.
Yeah.
And so it's when their cycle ends, they can start, after the bleeding cycle ends, they get an ovulation kit. You can go to the local drugstore and get one of those, get it online on Amazon, and you can start testing your morning urine. And as soon as that ovulation kit tests positive, then count forward in your calendar 5 to 7 days, and you want to be taking that urine sample in that 5, 6, or 7 day window, right? Yeah. And it doesn't matter if your cycle is 45 days and 1 month and 16 days another. The best thing to do is use an ovulation kit in that situation to try and figure out when that process is. And that's if you're doing the 1 day test. So there's 2 ways to do the test. And I'll tell you what, I'll let you kind of explain the 2 ways that that hormone testing can be done for women who are still ovulating.
You mean from the times that they do the urine test?
Well, some women, so there's 2 ways to do it, right? They could do an ovulation cycle test, right?
Yeah.
Or they could do a 1 day test. What I was kind of explaining was that 1 day test, right? So they don't want to. The problem is they can look at the full cycle. The problem is you got to collect a sample like every other day, right? So you're looking at the sample, and if they miss a day, you're starting over. And so it takes a month to collect the cycle, all the samples. If you do it right, it takes about a month to get it sent to the lab, the results, and get those results back to the doctor. So you're almost looking at 2 months until you find out what's going on. So I don't run as many of the cycling tests as I run the one-shot tests.
Yeah, that's usually what I usually run, the one-shot test, because it's just, usually we can do the ovulation kit, we can catch them in that time and we can get it back quicker. I mean, a lot of these people want to get better as fast as they possibly can, and so that's just a very easy thing to do, is just, either have them do the ovulation kit, or you just have them count from the first day of their cycle till that day, 2022 day, and then do the test. Takes a couple weeks to get the results back, and then we can start supporting that as soon as possible.
Right. And so, if you know that, that's where, if they know they're regular, then they're probably pretty good. If they're not, I really recommend that ovulation kit, because I've seen some people who thought they had a problem, but they just missed their day. They just missed their window. So you hate to have them do the test. You can see that they just missed their window and they really need to do the test over again. So if you're a man and you've got hormone problems and you don't have to really worry about a day of a cycle, you can take it pretty much any day. If you're postmenopausal and you're certain you're postmenopausal and not just just that you don't have amenorrhea, where you just don't have a cycle, but you're in that age frame where you should be having a cycle. If you're postmenopausal, definitely at that stage of life where you're postmenopausal, then you can do it whenever. But if you're cycling or you're at the age where you should be cycling, then I recommend you get enough. If you know you're cycling, you got a 28-day cycle, you know exactly when you ovulate, you can do that. Just follow the directions in the test kit. But if you're not sure when it is, or you're mid-40s and you're not sure, I'm premenopausal, not sure, I haven't had a cycle, I'm on and off, the best bet is get the kit, get the ovulation kit, follow that, and when you have once you ovulate, you count forward 5 to 7 days and catch it within that window. I think we've covered probably most of what we want to cover. I don't know that we really need to get into treatments or supplements or anything like that necessarily. I think the biggest thing for today's podcast was to understand that there's definitely a connection between having hypothyroidism, whether it's a glandular problem or a cellular problem. It definitely can influence hormones, estrogen, progesterone, prolactin, LH, FSH, testosterone. It influences cortisol. And all of those hormones also influence thyroid function. So it's important to not just look at the sex hormones or just look at adrenals. We have to look at all the hormones essentially together to get the most information out of what's going on, right?
You need the big picture, that's for sure.
You need the 30,000-foot view, exactly. So I think we've covered almost everything we need to cover today as kind of a summary. And what we'll do is I've talked to Dr. Jones, and she's more than willing to come on and we can interview her and she can talk to our listeners more about the Dutch test and more about hormones. And she's brilliant on the topic and on the subject. And she can we'll let her we'll pull some extra information out of her. And then I think in the future podcast, along with talking to Dr. Jones, we can break down a little bit more in depth the connection between each one of these hormones. And then we can give some advice and some guidance maybe on support when these things when they're having problems with individual hormones or individual patterns.
Absolutely. Because we could sit here and talk all day about lifestyle and diet and foods that impact all that stuff. But, we just wanted to give you a little bit of an intro today, and then we can dive deep on other podcasts.
Yep. So I think we'll wrap that up today. I think that we covered it pretty well. As we go, obviously the Thyroid Answers podcast is available on iTunes, so you can always get it. You can always go to iTunes and download it there. It's always helpful if you like what we're doing on the Thyroid Answers podcast to please leave some reviews there. That helps us out. Please tell your friends and family members and people have thyroid problems to join in, to listen in. If you have questions, wherever you see the Thyroid Answers podcast, if you watch it on video or you watch it on Dr. Erica's site or my site and you have questions, you can leave questions below wherever you see it. Usually there's a comment section, or you can call Dr. Erica's office or my office if you have some interest in having us help you with your thyroid or hormone condition. You can find Dr. Erica at
Brain and Body Health Center on Facebook. You can find us at brainandbodyhealthcenter.com. We have Dr. Riggleman at, that's going to be Instagram, Twitter, and we also have YouTube.
Awesome. And my office is chronicconditionrecoverycenter.com. That's my main office website. I also have thyroidproblemsdoctor.com is my thyroid specific website. And on Facebook, you can find me at Chronic Condition Recovery Center. But I think that's it for today, Dr. Erica. I think we did what we can do with a summary of thyroid function and its relationship or connection to the sex and adrenal hormones. So we'll end with that. It was a great podcast today. It was great talking to you, and hopefully our listeners got a lot out of this podcast. So have a great day. Okay.
Absolutely. Thanks.
You got it. Take care.
You too.